Good evening, chairpersons, delegates, and faculties. And at the outset, I thank the NELCON organizers and Dr. Charu Garg for giving me the opportunity today. So, in next 15 minutes, I'll try to show whatever knowledge and evidences I could gather on this topic, whole brain radiotherapy with hippocampal sparing, when not. So, how many of you can identify this famous person or this famous neurosurgeon? I know who are interested in neuro-oncology can readily recognize these two persons. Yes, this is the famous patient, Mr. Henry Molaison, and the famous neurosurgeon, Dr. William Beecher Scoville. So how they are related to this talk? In 1953, Dr. Scoville did a surgery on Mr. Henry Molaison for intractable epilepsy. And the surgery was bitemporal medial lobectomy. So what happened after that? The patient HM after the surgery was studied extensively, and most of our knowledge on the function of the brain is actually the contribution of patient HM. After the surgery, the patient developed anterograde amnesia. That is, he could remember whatever he memorized before the surgery, but he could not register any new memory. So that is because his hippocampus was removed during this surgery. Hippocampus is a paired organ and part of the puppet circuit, and it is the responsible for storing and recollecting the memory. Whole brain radiotherapy was considered as a palliative technique for terminally ill patients, but recently, with improved survival, with novel systemic therapies, the quality of life of the patient has also become a very important factor. And this article, published by Dr. Vinay Gonde in 2014, called RTOG 0933, changed our outlook on whole brain radiotherapy. This phase 2 trial, preservation of memory with conformal avoidance of hippocampal neural stem cell during whole brain radiotherapy for brain mets, showed that there is 30% reduction in neurocognitive toxicity compared to historical control if the hippocampus is avoided during whole brain radiotherapy. And the same group did a phase 3 trial, Energy CC001, comparing hippocampal avoidance with whole brain RT and memantine and non-hippocampal avoidance with memantine, whole brain radiotherapy with memantine. And they have shown that hippocampal avoidance prevents cognitive function failure with 26% relative rate reduction. And it starts at 3 months and was continued throughout the follow-up period. And they concluded hippocampal avoidance during whole brain RT plus memantine for brain metastasis better preserved neurocognitive function and patient-reported outcomes while achieving similar intracranial control and survival. But we need to keep in the mind that they excluded all the patients who had hydrocephalus or ventricular distortion, and all the patients were undergone 3D MRI. So question is, how many of our patients will be eligible for this? Mainly the elderly patients. But the impact of this trial was so much that NCCN in their guideline mentioned for brain metastasis, patient eligible to receive whole brain radiotherapy and whose survival is expected to be 4 months or longer, hippocampal avoidance using IMRT should be considered standard of care. So as this is a lung cancer conference, I'll discuss only the scenarios associated with lung cancer. So we have two situations. One is prophylactic cranial radiation for small cell lung cancer and another for brain metastasis. So for PCI in small cell lung cancer, can you spare the hippocampus? So this is a safety profile study done by Dr. Vinay Gandhi in 2014 with 70 patients data and showed that the overall incidence of hippocampal metastasis before or after whole brain radiotherapy in small cell lung cancer patient is actually low. This data preliminary support for safety of hippocampal avoidance during a planned clinical trial of hippocampal avoidance whole brain RT for small cell lung cancer. And this is another bigger data of 120 patients with 754 mets presented in ASTRO 2018 from Australia showed that there were 22 patients with hippocampal metastasis. That is 18.3% of their cohort. And total 23 metastases involved the hippocampal avoidance area. And they concluded that overall incidence of hippocampal metastasis in their cohort of SCLC patient is high, as hippocampal sparing whole brain RT may increase the risk of treatment failure in the spared region. Prospective randomized trial are encouraged. So these, in ASTRO 2018, two very important abstracts of phase 3 trial of PCI with or without hippocampal avoidance was presented back to back, one from Netherlands and another from Spain. So the Dutch randomized phase 3 trial of 168 patients investigated the safety and reports on the incidence and location of the brain metastasis after treatment with hippocampal avoidance PCI compared to standard PCI. With a median follow-up of 24.6 months, there was no significant difference in the incidence of brain metastasis between the two arms. None of the patients developed a single brain metastasis in the hippocampus or hippocampal avoidance area. And the second one is the Spanish Premier trial data. A result of 118 patients shows there was a significant decline in memory in PCI group. Further investigation to assess its impact on long term is actually going on. The Dutch group in ISTO 38 2019 presented their preliminary result and showing that HVLT R total recall score was more than equal to 5 points lower compared to baseline, and it is 28% in PCI group and 29% in hippocampal avoidance PCI group at 4 months. The p-value was not significant. Even at 8 months, it was 34% and 26%, and at 8 months also the p-value is not significant. And they concluded there is no significant difference between the two arms was seen. The incidence of brain recurrence was also not increased in the avoidance area. So now all eyes are on this ongoing energy CC003 trial by Dr. Sayan, Binoy Gandhi and team. And this is a randomized trial of PCI with or without hippocampal avoidance. Following accrual of 182 patients in phase 2, they have analyzed the phase 2 data and they have again accrued 122 patients, and the trial, phase 3 trial is going on. So let's see what ASTRO Clinical Practice Guideline 2022 says. Strategies to reduce the risk of neurotoxicity, including medical intervention and hippocampal avoidance PCI, are currently being assessed in ongoing clinical trial, that is Energy CC003, and the rate of brain metastatic failure from this approach is yet to be defined in this population. So as per available evidences, till date, we cannot practice hippocampal avoidance PCI in SCLC in our clinic. Now for brain metastasis, the stage has already been set by my favorite senior, Dr. Kundan Singh Chofal, so making my job very easy. This trial shown by Dr. Kundan Singh Chofal is a meta-analysis by Dr. Arjun Sehgal, and what they have shown is they established SRS as standard of care for patient less than 50 years, is 1 to 4 brain metastasis, and 59%, that is total 214 patients of lung cancer was there in this cohort. And this trial, this data also as shown by Dr. Chopal is the Japanese trial data of 1,194 patients, and they have shown in 3 groups, 1 metastasis, 2 to 4 metastasis, and 5 to 10 brain metastasis, non-inferiority of SRS alone for patient with 5 to 10 brain mets versus 2 to 4 brain mets. And this is a very interesting analysis. It was published in 2019 by Dr. Binay Gondi on the same RTOG 0933 data, and see what they have concluded. In patient receiving hippocampal avoidance whole brain RT for brain metastasis, extent of pretreatment white matter injury predicts post-treatment memory decline. That suggests a mechanism of radiation therapy-induced neurocognitive toxicity independent of hippocampal stem cell radiosensitivity. Stability or improvement in HVLT after hippocampal avoidance whole brain RT for patients with higher pretreatment intracranial metastatic burden supports the importance of whole brain RT-induced intracranial control on neurocognition. So, sparing the hippocampus may not be enough in some cases. Radiation-induced cognitive impairment likely involves dynamic interaction between multiple cell types in the brain. Brain irradiation causes changes in the vasculature, glial cell population, hippocampal neurogenesis, altered neuronal function, and elicit neuroinflammation. All these pathways likely contribute to the development of radiation-induced cognitive impairment. So this is an ongoing Canadian trial, and it is actually comparing SRS versus hippocampal avoidance whole brain radiotherapy plus memantine for 5 to 10 brain metastases, and probably will reach to some conclusion once the result is declared. So we agreed that dose to hippocampus is important to some extent for neurocognition, and theoretically, any dose can produce damage to hippocampal neuroprogenitor cells. So let us compare from available data how much mean dose we can achieve from the existing technique. So for LINAC, it is 4.9 gray. In tomotherapy, whole brain RT, 7.3 gray. For proton, it is 4.4 gray, whereas for SRS, it is 1.6 gray. And if you do a hippocampal sparing, it is only 0.78 gray. So if we want to protect hippocampus, then why not hippocampal avoidance SRS? So let's see what the NICE guideline, which is followed in UK, says. They have said consider maximal local therapy, the surgery or SRS or SRT for single brain metastasis. Consider SRS or SRT for multiple brain metastasis where KPS is more than 70 and the extracranial disease is controllable. And do not offer whole brain radiotherapy to people with non-small cell lung cancer and brain metastases that are not suitable for surgery, SRS or SRT, and the KPS is less than 17. Because of the published QUARTZ trial, which shows that best supportive care with dexamethasone is non-inferior to whole brain radiotherapy in this group of patients. And they have also said do not offer memantine, which is also a neuroprotector, in addition to whole brain radiotherapy to people with multiple brain metastases, unless as part of a clinical trial. So in the
Dr.
clinic,
Sayan,
yeah.
Dr. Sayan, you have 3 minutes left.
Okay, fine, I'll finish, no problem. So in the clinic, when a patient with brain mets come, our medical oncology colleagues will have a basket full of options, multiple line of systemic treatment, and he will send the patient to a radiation oncologist. Then we are in dilemma which technique to be used. In this regard, the health economics comes into picture. It is not only the cost of the treatment treatment technique, it also includes the travel and stay of the patient, the duration of the patient. Maybe SRS per se can cost more, but if you combine travel and stay of the patient for 2 weeks for whole brain RT, it might be costlier than SRS. And also, we need to assess whether the patient has access to this immunotherapy targeted therapy. Is he affordable to do this? Will he or she be continuing the systemic treatment? Is there a compliance to imaging follow-up or physical follow-up? And is the patient affordable of retreatment? So considering all these factors, we need to decide which treatment to be offered, obviously with whatever available evidences we have in this scenario. So I again thank you, the NALCON organizers, and because of this topic, I could read this fantastic book, Patient AHM, written by Luke Dietrich. And you know who is Luke Dietrich? He is the grandson of our neurosurgeon, Dr. William Beecher Scoville. I acknowledge Dr. Impa Bosu Achari for guiding me for preparing this presentation. My friend, Dr. Bimoj Nair, who is a part of the Canadian trial, and he also guided me a lot, and Dr. Kanu Charan Patro. And thank you all for your patience.